Good evening, good morning, good night, depending on when you are. Welcome to the UEG webinar on chronic mesenteric ischemia. This webinar will be discussing chronic mesenteric ischemia and illustrate the very recently published guidelines in the UEG journal, which is the result of a tremendous collective effort. Please let us know if you don't hear us very well. My name is Maxime Ronot. I'm a radiologist, both diagnostic and interventional radiologist. And I work in Clichy, France, and I'm part of a dedicated stroke center unit for mesenteric ischemia. It is my pleasure today to moderate the session, and we will have two worldwide recognized experts on chronic mesenteric ischemia. The first will be Luc Terlouw, who is an expert in Erasmus MC University in Rotterdam. He's part of the outpatient clinic for mesenteric ischemia, and it actually the reason why, one of the main reasons why these guidelines were published, he coordinated the collective effort. And the second expert is Alexandre Nuzzo from France, the same institution I work in Clichy, and he is an active member of the intestinal stroke center unit of the institution. I would like to remind you that you can ask questions using the chat function. So please feel free. We will try to address all your questions during the webinar. If you experience technical difficulties, be patient, do not panic. It may be possible, stay calm, and we will try to fix this for you. To start, I would like to start with a mini survey to maybe get a little bit about your expertise and your background. So this is a way for us to start the polls. What is your expertise? Are you a gastroenterologist, a radiologist, a surgeon, an intensive care a physician, internal medicine physician, or something else? So I see that, I would say as expected, the majority of you are gastroenterologists, but we also have a significant subgroup with surgeon, and I think there is a other 9%. Great, so you can we know who we are talking to, and I think now it's time for me to give the floor to Alexandre, who is going to start presenting the first part of the presence.
Thank you very much, Maxime. Thank you, the UEG, for this invitation to discuss these guidelines. It's my pleasure to be here. So this will be the workflow of the presentation. I will start with the diagnosis part, and then Luc will review the recommendations about therapy and follow-up of these patients. So let's get started with the diagnosis. So, as you well know, chronic mesenteric ischemia corresponds to a GI condition, a GI injury, which occurs when the small bowel doesn't get as much blood and oxygen as it needs. This injury is usually painful and will be typically triggered or revealed after a meal, because it's during a meal when the small bowel needs more blood, when the small bowel works harder. Indeed, the blood supply of the blood supply demand increases by 150% during the digestion, and so inadequate blood supply during digestion after a meal, will lead to GI injury and GI symptoms. Basically, chronic mesenteric ischemia is a similar process as cardiac stable angina, where chest pain is triggered by physical exertion, except that in mesenteric ischemia, the physical exertion is the meal, is the food ingestion. So, first of all, maybe I hand over to Maxime for the question.
Yeah, we have a first question for you. How often do you diagnose a patient with CMI in your practice? 0 to 1 time a year. Okay, I'm waiting for the. Okay, so 2 to 5 times per year, 5 to 10 times, or more than 10 times. So we see as polls are accumulating, that's roughly 2/3 of you guys seem to see very rarely patients with chronic mesenteric ischemia, and one big third, 2 to 5 times. We have only few of you that see more than that. So can you comment maybe Alexandre, on that?
Yeah, of course. So we will move to the next slide to comment it. So the prevalence, the incidence of mesenteric ischemia has been reviewed recently by the team of Luke in the Netherlands, and they evaluated the incidence was 9 per 100,000 person years, which is quite high actually. It's not a rare disease. It's just half the incidence of IBD, for example. And when I applied these incidents to the French population and the French gastroenterologists, actually it means that on average, every gastroenterologist should see at least 1 or 2 patients, should diagnose at least 1 or 2 patients per year. And of course, it depends on where the gastroenterologist work. And at least we expect a higher incidence at the hospital. And this incidence, what's important is that this incidence is probably highly underestimated due to diagnosis difficulties. And this is in link with the very high prevalence of mesenteric artery stenosis. As you can see, the prevalence of the stenosis, it doesn't mean it's symptomatic, and the prevalence of the stenosis are up to 6 to 29% of population, and it goes up to 50% of patients with vascular comorbidities. So it's quite normal that given the prevalence of the stenosis, the incidence should be maybe higher. So we'll review now the cause of CMI. The first and leading cause of splanchnic vascular lesion is atherosclerosis. In CMI, there is a female preponderance with classical vascular risk factors, smoking, hypertension, etc. And the second cause, and this is the leading cause actually, the second cause, really much rarer. The second cause is median arcuate ligament syndrome, MALS, which is, as you can see on the middle figure, it is a diaphragm ligament which presses on the celiac artery. Risk factors are usually young women with low BMI. And a last cause to bear in mind is chronic NOMI, chronic non-occlusive mesenteric ischemia, which means non-occlusive means that the mesenteric vessels are normal, but the insufficient blood and oxygen supply to the small bowel comes from systemic low flow state or systemic hypoxia. This can lead to repeated vasospasm of the mesenteric arteries in response to this systemic low blood flow or hypoxia. It's quite rare, but it's something to bear in mind in patients with symptoms that are unexplained and weight loss unexplained. So when should we consider chronic mesenteric ischemia? So the symptoms of GI injury, mostly but not always, involve severe abdominal pain. And this severe abdominal pain will generally follow and be repeated after meals and after every meal. Usually patients are without symptoms after a period of fasting, and the pain after every meal will lead to a fear of eating and will lead to weight loss. Also, due to repeated mucosal injuries, chronic diarrhea can occur. However, as you can see, this classical triad is quite rare. The classical triad is postprandial abdominal pain, weight loss due to the fear of eating, and an abdominal bruit during the physical examination. And as you can see, this complete triad is only present in 22% of patients and has a low predictive value. So that means that we cannot exclude the diagnosis of CMI when this triad is absent, and that means that we should have a wide suspicion of this kind of diagnosis. And so, given the injuries repeated by meals and in between meals, the GI tract and the GI potential lesions can heal. CMI can lead to a normal test, and sometimes lab tests, CT scan, endoscopy is totally normal. So, and sometimes you can have lesions that can mimic a lot of other GI diseases with intermittent GI ischemia leading to repeated ischemic pancreatitis, for example, repeated ulcers, atrophy, mucosal atrophy, and as well, one of the diagnoses, differential diagnosis is irritable bowel syndrome. As I said, the exploration, CT scan, endoscopy can be totally normal and doesn't rule out the diagnosis. So that's why CMI is considered a diagnostic challenge. And that's why to rule in the diagnosis, we should exclude all the alternative diagnoses. Usually the diagnosis rely on compatible history, compatible symptoms, repeated by meals, with an emphasis on the postprandial pattern and an emphasis on a change in how patients eat in response to their symptoms. So the first thing is the compatible history and GI symptoms. The second thing, the second part of the diagnosis is the constatation of significant mesenteric artery stenosis on the CT scan or another imaging. And the third thing is rule out the alternative diagnosis. And preferably, if available, there are some functional tests that can increase the suspicion and the diagnosis probability of the disease. Given that the diagnosis can be a challenge, the UEG experts concluded that such a diagnosis should be discussed in an expert team before revascularization be proposed.
So we have another question for you. At least 2 out of 3 mesenteric vessels should be stenotic to establish, let's say, a presumptive diagnosis of atherosclerotic CMI. Would you consider it to be true, false, or you actually do not know? So you see, I think that there is a struggle between the two kinds of blue, but let's say half of the audience believe it's not true, and close to 40% would say it's true, and we have a small undetermined people. So Alexandre, what is the correct answer of that question?
So actually, it's the correct answer is false. It's an old theory, but there's kind of true in the answer. Can we move to the next slide? Yeah. So yes, it's an old theory, but actually, indeed, the more the vessels are affected, the more likely the diagnosis will be. And so usually it's when you have the multivessel disease is when you have a lesion and significant stenosis of the superior mesenteric artery and a stenosis of the celiac artery. Usually in mesenteric ischemia, the value or the impact of a stenosis or occlusion of the inferior mesenteric artery is considered minor. And so when you have a multivessel disease, I mean celiac artery and SMA significant stenosis, as you can see, the probability of CMI with GI symptoms compatible is very high. And so the clinical success of treatment is very high. In this setting, the UEG experts recommended that a functional test is not really required, and we are quite confident with the diagnosis, and we can propose revascularization. But actually, there is around 30% of patients who have true and authentic chronic mesenteric ischemia with only one vessel involved, especially when the SMA, the superior mesenteric artery, is involved. And so obviously the CMI probability is a bit lower, but still up to 40% of patients with single vessel disease have CMI, and the probability of success is around 70%. So in this setting, the UAG recommendation were to make a minimum workup to rule out other diagnoses. I think in this setting, single vessel disease, it's even more important to rule out other disease responsible for the GI symptoms. And in these patients, the symptoms should be a bit more typical to be confident with this diagnosis. So the postprandial pain and this postprandial pain should be accompanied by either weight loss or an adapted eating pattern. And so that's in this case, in single vessel disease, or when the doctors are still not fully confident in the diagnosis to propose revascularization, we have some functional tests, especially assessed in the Netherlands. That almost all the studies come from the Netherlands. They have more experience in that. In France, we have the visible light spectroscopy now for 1 year. And actually, these two tests, VLS and gastrointestinal tonometry, are functional tests that can increase the probability of the disease. Visible light spectroscopy basically measures the saturation in oxygen of the mucosal of the mucosa of the stomach and the duodenum during an endoscopy with fiber optic catheter that will measure the oxygen. And the Netherlands, the Dutch teams showed that there was a high sensitivity in this technique, and there were cutoff of low saturation value that would be predictive of the success of the revascularization. So in case when it's difficult to conclude whether CMI is present or not, these can be very important tools. The other tool you can have is gastrointestinal tonometry. We don't have this in France. Maybe you have in other teams. We can discuss this later. And these tests rely on the measurement of the carbon dioxide in the stomach, which is linked to ischemia in these studies. And this measurement is made with a nasogastric tube. The third and last setting of the disease, and probably the most challenging, is the setting of chronic non-occlusive mesenteric ischemia. So these are patients where the diagnosis of chronic mesenteric ischemia will be evoked facing compatible symptoms, left unexplained with weight loss, postprandial pain, and with normal mesenteric artery on the CT scan or on imaging. And I think that's something we should bear in mind, that in patients with systemic low cardiac output, with systemic hypoxia like COPD, we should bear in mind that sometimes these underlying disease can trigger vasospasm of mesenteric ischemia. That's something that is not visible on the CT scan, but I think in this patient we should bear in mind this and evoke chronic mesenteric ischemia when all the alternative diagnoses are ruled out. But usually in this case, single vessel disease or chronic NOMI, the diagnosis should be discussed with an expert team. I now
Alexandre, if I may.
Yeah.
I'm sorry, just a quick question to interrupt from the audience. You talked about meals triggering the pain and one of the key diagnostic feature. Are there any other precipitating factor other than the meals? I don't know, for instance, effort or something else that could be considered as a trigger?
That's a good question. There are some case reports of patients, and I have in mind some patients that suffer from pain during physical exertion. So I think that could be, and also sometimes even when there is a stenosis, significant stenosis and disease, every underlying cause that will decrease the blood flow in the superior mesenteric artemia, in the superior mesenteric artery, can trigger the pain or trigger the symptoms. So usually it's after meals, because the blood flow demand of the small bowel increases in after meals. But during physical exertion or hypovolemia or dehydration can be a trigger of the pain or of the GI lesions as well. And we have sometimes, usually in diabetic patients or in some patients, pain is lacking. And so that can be very confusing. Sometimes we have patients presenting with only chronic diarrhea. And I think when chronic symptoms, we should suspect very widely chronic mesenteric ischemia when we have chronic GI symptoms that are left unexplained after a very exhaustive workup.
Okay, then I will continue to discuss the available diagnostic tools for chronic mesenteric ischemia, and I will be covering the other question in the Q&A as well later on in the presentation. And I'll actually start with more kind of a message, because biomarkers, the first diagnostic tool, those are not available for the detection of mesenteric ischemia. And all clinicians should be aware of the very low sensitivity of lactate for the detection of both acute and chronic mesenteric ischemia. So I would like to emphasize that the normal lactate value absolutely doesn't exclude the presence of mesenteric ischemia. Then we'll continue with another question.
So does a non-remarkable upper GI endoscopy can exclude the diagnosis of CMI? So do you think it's true? You would say no, but it would become less likely, or no, it's frequently non-remarkable in CMI patients. I think now we have a vast majority of the audience voting for C. So what do you think, Luc?
The correct answer is indeed answer C. And if we can switch back to the presentation, I'll show you the next slide. Because endoscopy in patients with suspected chronic mesenteric ischemia is mainly used to exclude alternative diagnoses. And the main reason is that the prevalence of endoscopic findings is relatively low. And even when present, these endoscopic findings are mainly non-specific and often transient. So a normal GI endoscopy doesn't exclude CMI. And I saw a question regarding plain biopsies in the Q&A chat. And biopsies are not sensitive enough for the detection of mesenteric ischemia. The ischemia in chronic mesenteric ischemia patients is often transient and mainly after meals. And therefore, actual sustaining mucosal damage is not necessarily present. So you can miss the diagnosis when you're only taking biopsies. Another important diagnostic tool is CDA. And CDA is the preferred imaging modality for the detection of mesenteric artery stenosis. And 1 or less than 1 millimeter slice thickness is required to reliably assess stenosis severity. And besides an arterial contrast enhancement phase, a venous or portal venous phase is required to detect potential extravascular signs of acute mesenteric ischemia. Contrast enhanced magnetic resonance imaging is another technique, and this is actually the technique of choice in patients with contraindications for CTA. And the sensitivity and specificity of contrast enhanced MRA are actually comparable with those of CDA. So it's a good alternative. Duplex ultrasound is also frequently performed, but it has several limitations, such as the wide range of cutoffs that have been proposed to define the mesenteric artery stenosis, the strong operator dependency, and the inability to adequately image the more distal sections of the superior mesenteric artery. So the experts recommend that duplex ultrasound may be performed, but mostly as a screening method to exclude significant proximal mesenteric artery stenosis. And in case you have a positive duplex ultrasound result, you will always have to proceed with an additional CTA or MRA in order to confirm presence of the stenosis and in order to reliably assess stenosis severity. There are no comparative studies on the available imaging techniques for the detection of celiac artery compression. And experts do agree that duplex ultrasound, CTA, or contrast enhanced MRA are all adequate techniques for the detection of celiac artery compression. However, most of the patients with suspected median arcuate ligament syndrome are of younger age, and in those patients it might be preferable to perform duplex ultrasound or contrast enhanced MRA in order to avoid radiation exposure. And when you're performing imaging in a patient with suspected celiac artery compression, you must be aware of the maximal stenosis severity, which is observed during expiration. And a study has shown that 44% of the patients with a stenosis during expiration did no longer have a stenosis during maximal inspiration. So in order to reliably detect celiac artery compression, you should perform imaging during both an inspiratory and expiratory breath hold. Then we'll continue with another question.
So consider a 72-year-old female patient presenting with postprandial abdominal pain and unexplained weight loss. She's referred to your outpatient clinic, and she underwent recent upper GI endoscopy and abdominal ultrasound that were non-remarkable. So you would consider CMI as a possible diagnosis. Which tests do you perform? Functional testing, with the one we talked about. You perform digital subtraction angiography, contrast-enhanced magnetic resonance angiography during both an inspiratory and expiratory breath hold, or you would perform arterial and portal venous CTA. Here, the CTA is gathering most of the votes, but you also close to 15% of the audience would choose contrast-enhanced MRI. So, Luke, what can we say about that?
In this patient, I would prefer answer D. First step would be to assess whether any mesenteric artery stenosis are present, even before performing a functional test. So at first you would like to see, are there any vascular occlusions? So in this case, CDA is the best technique because it's non-invasive. Digital subtraction angiography is an invasive technique, and the results of CTA imaging are quite good, so that would be the first choice. And contrast enhanced MRA is mainly indicated in case of contraindications for CTA.
Okay, it's a 20-year-old female patient, also presenting with abdominal pain during exercise. She tells you that she has lost 5 kilos of weight because she's afraid of eating due to severe abdominal pain after eating. She had previous extensive diagnostic testing that did not result in an alternative diagnosis, so you'd consider mouse. What strategy is best to perform in this patient? Contrast-enhanced MRA during both inspiration and expiration. Again, arterial and portal venous CTA, DSA, or inspiration and expiratory duplex ultrasound. So here, the audience is split between the two possible inspiratory and expiratory tests, but you see slightly more in favor of the duplex ultrasound. Here, the CT scan is really really not the choice. So Luke, what would you have chosen?
Yeah. The main thing is that this is a relatively young patient, so atherosclerotic lesions are not that probable, and median artery ligament syndrome, so celiac artery compression, is more probable. And in this case, you would at least need both inspiratory and expiratory imaging. So both answer A and answer D are correct. And yeah, that are the main reasons. Now we've discussed the available diagnostic tools. We'll continue with an overview of possible therapeutic interventions. And in the past, surgical mesenteric artery revascularization was the main treatment of choice in order to revascularize mesenteric arteries. And in the early days of endovascular revascularization, PTA and percutaneous mesenteric artery stenting was mainly reserved for patients not eligible for surgical revascularization. However, in more recent years, we've seen a shift towards an endovascular revascularization first strategy. So that is the strategy most commonly used by most centers nowadays. And when you're looking at the evidence, then there are quite a lot of studies, but they're all retrospective cohort studies and smaller case studies. And the best available evidence are several meta-analyses pooling the data of these individual studies. And they've shown that surgical revascularization is associated with a significantly higher in-hospital complication rate and a trend towards a higher 30-day mortality rate. And they've also shown that there's a trend towards a lower rate of symptom recurrence after surgical revascularization, which is of course beneficial. When you're discussing durability of the revascularization, it's often expressed as patency. And primary patency means that there's absence of a restenosis or reocclusion of the target vessel after the initial revascularization procedure. And these meta-analyses show that the 5-year primary patency of endovascular revascularization is substantially lower than the 5-year primary patency of surgical revascularization. And also the 5-year secondary patency, defined as absence of a restenosis or reocclusion after a second target vessel revascularization, is lower after endovascular revascularization, 88% in this case. And the expert panel has weighed all the evidence, and they reached consensus on the recommendation that mesenteric bypass procedures might be reserved for patients in whom endovascular revascularization is not suitable. And the main reasons to conclude that mesenteric bypass procedures might be reserved for patients not eligible for endovascular revascularization is that the short-term benefits of endovascular revascularization, because it's mainly minimal invasive, outweigh the superior long-term results of surgical revascularization. And it's also because the population of CMI patients is mainly of older age, are fragile patients, and frequently have multiple comorbidities. And a second reason is that the long-term patency of repeated endovascular revascularization is actually comparable with the long-term patency of surgical revascularization. So as long as you're willing to perform multiple endovascular revascularization procedures, you'll be able to reach an excellent patency rate. The expert panel unanimously agreed and recommended that in atherosclerotic mesenteric artery lesions, percutaneous mesenteric artery stenting is preferred over PTA alone. The main reasons were that the technical success rate of percutaneous mesenteric artery stenting is higher than the technical success rate of PTA, and the notion that most of the mesenteric artery stenosis occur at the origin of the vessel, and these stenoses are often heavily calcified, And similar to renal artery stenosis, these stenoses were heavily calcified at the origin of vessels tend to show elastic recoil. And that's meaning that after the PTA, the vessel walls tend to return to their previous position, causing recurrence of the stenosis. And when you're stenting the artery, you prevent the recurrence from happening and thereby making sure that the revascularization procedure has good results. In patients with mesenteric artery stenosis of both the celiac artery and superior mesenteric artery, the question is often raised whether you should perform revascularization of one artery or of both the celiac artery and superior mesenteric artery. And the expert panel recommended that in patients with occlusive disease of both the celiac artery and superior mesenteric artery, endovascular revascularization of both vessels might be attempted, but that the superior mesenteric artery is the preferred target artery, followed by the celiac artery. And this is mainly based on older studies, cohort studies and case series of mesenteric bypass procedures. And these studies have shown actually quite good results after superior mesenteric artery bypass grafting alone. But when they performed complete revascularization procedures, there was a trend towards a higher 5-year survival and a significantly higher long-term freedom from symptom recurrence.
So now we're going to consider a 75-year-old male patient presenting with postprandial abdominal pain, unexplained weight loss, recent upper GI and ultrasound non-remarkable, and the CTA showed significant atherosclerotic stenosis in both the celiac artery and the superior mesenteric artery. So what would be the next step? Functional testing or celiac artery release, mesenteric bypass procedure, or percutaneous mesenteric artery stenting? Just to test your short-term memory. So here you see vast majority of the audience is in favor of D, the percutaneous mesenteric artery stenting. We have a few mesenteric bypasses, likely to be our surgeon friends, and very few in favor of more exploration. So Luke, which should we favor?
Mm-hmm. The correct answer is indeed answer D. And as discussed by Alexandre, this is a patient with a stenosis of both the celiac artery and superior mesenteric artery, so a functional test is not necessarily required, so you can proceed to treatment, and in this case the correct answer would be stenting first, so endovascular first. The diagnosis of median arcuate ligament syndrome remains controversial, but experts do agree that when you decide to perform treatment in patients with presumptive median arcuate ligament syndrome, that you should consider surgical celiac artery release procedures. And these procedures are performed by dissecting the median arcuate ligament, and a systematic review of over 400 patients has shown that 83% of patients show an initial improvement of symptoms, and 80% of patients experience sustained long-term improvement of their symptoms after a celiac artery release procedure. And these clinical success rates are quite high, but I should mention that the underlying evidence are mainly smaller case series. So those are of course prone to publication bias influencing these results. The expert panel also recommended that percutaneous mesenteric artery stenting of the celiac artery is contraindicated in patients with median arcuate ligament syndrome with no preceding celiac artery release procedure. And the main reason is the high risk of stent fracture. The stent would be constantly compressed and manipulated by the median arcuate ligaments during breathing, and this could cause a fracture of the stent with subsequent stent occlusion and ultimately potential acute mesenteric ischemia, which is of course something you would like to avoid. So celiac artery release procedure first before you even consider stenting.
So now to illustrate that, we have a 23-year-old female patient with weight loss, postprandial and exercise-induced abdominal pain. Previous extensive diagnostic testing did not result in a definite diagnosis, and she underwent contrast MRI inspiratory and expiratory phase, showing the compression of the celiac artery. Mucosal saturation were decreased during VLS, so she had the functional test because it was a single artery issue. With treatment, it preferred in patient with MALS. So here again, celiac artery release procedure, percutaneous mesentery stenting. We see that the audience really favors A, the celiac artery release procedure, the one you just talked about. We still have a few voting for vasodilatating agents or mesenteric bypass procedure, which is, I think, something that's not really considered in these patients. Would you agree, Luc?
I fully agree. Yeah. The treatment of choice in this case would be a celiac artery release procedure. So that's the correct answer indeed. And percutaneous mesenteric artery stenting, as just discussed, is contraindicated due to the risk of stent fracture with the subsequent risk of stent occlusion. This flowchart shows a comprehensive recap of the diagnostic workup of patients with suspected chronic mesenteric ischemia, and this flowchart can be found in the full version of the guidelines, which is available in the UEG standards and guidelines repository, and an extended version of this flowchart will soon become available in the GI guideline app. I would like to thank all the participating experts and endorsing member societies for their contribution to these guidelines. And I would like to thank UEG for the opportunity to present these guidelines during this webinar.
Thank you very much, Luc. Thank you, Alexandre. I think we have time now for maybe a few questions from the audience and discussions between us. This was really a very nice and comprehensive presentation you gave us. Maybe we can talk a little bit about the diagnosis phase, because you said that this is not such a rare disease, but it is likely to be underdiagnosed. But then when you provide the diagnostic symptoms, this is quite wide. So there is a risk that if everybody becomes sensitive to that, we might go from underdiagnosing to overdiagnosing. And you didn't mention the possibility of, let's say, stress tests when we talk about ischemia and chronic ischemia in other organs, for instance, heart, or we may do stress tests. Is there a room here for, let's say, provoked pain induced by a standardized meal that a patient would do during a short hospital stay, for instance, during which we could perform the functional imaging or functional test you talked about?
So if I make a comment on that?
Yeah, of course. Please.
That would be the ideal situation. Gastrointestinal tonometry, which is performed by positioning catheters and balloons in both the stomach and jejunum, is usually performed for a period of 24 hours. So these patients are submitted to the hospital for 24 hours, and they'll be eating as well, and they'll be getting standardized meals in order to provoke ischemia. But unfortunately, the equipment that is needed to perform gastrointestinal tonometry is no longer produced. So that test will soon cease to exist. So we're trying to find other good functional tests, but working on it.
And VLS and possibly tonometry, can you perform that? You need to perform that under general anesthesia or just sedation, or it can be local anesthesia?
VLS in our center is mainly or mostly performed under conscious sedation, and because you're performing an upper endoscopy, the patient, the stomach must be empty, so you can't provoke mesenteric ischemia. My colleague Louisa van Dijk has performed a study in which they performed VLS measurements shortly after a meal given by a nasogastric tube, and they had to wait 40 minutes after the meal to in order to perform the VLS measurement. So that was probably too late to really see any differences in mucosal saturations, because the meal had actually passed the sections that they were performing the VLS in. So that, yeah.
Maybe a question now that is in between diagnosis and treatment, and I will try to include questions I see from the audience. As you mentioned in the presentation, Alexandre told us that the prevalence of SMA stenosis in the general population is not rare. So we may see patients that actually seem to be asymptomatic, but for some reason they undergo abdominal CT, and we see very severe stenosis of both the celiac artery and the SMA. And now the question can be, should we do something for these patients? Should we do something before they become symptomatic? Or should we make really sure that they are not actually symptomatic? Because, so is there a room for preventive treatment? Alexandre, maybe you can comment on that.
So on the basis of the current evidence, I think given the potential morbidity and potential mortality as well of touching and the superior mesenteric artery, you can, the revascularization for an asymptomatic patient can trigger mesenteric ischemia. If it doesn't go well, if there is a surgical or endovascular procedure issue, you can precipitate acute mesenteric ischemia, and even there are some deaths after such procedures. So at the moment, the experts, but it's based on experts' advice, the experts recommend to not perform revascularization on asymptomatic patients unless a major vascular surgery or a major abdominal surgery is scheduled. So sometimes a major abdominal surgery, a major vascular surgery is where it may be at high risk of perioperative or after surgery, a very high risk of acute mesenteric ischemia. So in this setting, what's recommended is to revascularize before such a surgery. But the rule is when there are no symptoms,
okay,
we shouldn't touch the mesenteric arteries.
Yeah, there's actually not that much evidence on this topic. There are two very small studies on asymptomatic patients. And the first one is of Thomas, and they followed 15 asymptomatic patients with severe pre-vessel disease. So the celiac artery, superior mesenteric artery, and inferior mesenteric artery were all stenotic. And they observed that 27% of the patients developed either chronic or acute mesenteric ischemia over time. But that's over time, and there's always a period that the patient can become symptomatic and that you can act. And the other study had 24 patients also with asymptomatic stenosis of all three mesenteric arteries, and they observed symptoms of chronic mesenteric ischemia in 60% of patients. So the evidence is really limited to just a few cases reporting on these figures. And I saw a comment on secondary prevention. In one of the statements in the guideline is that in patients who are asymptomatic and in whom you find atherosclerotic stenosis, you should always consider to perform cardiovascular risk stratification in order to determine whether you should start aspirin or lipid-lowering agents, etc. So that's always something you should at least consider and evaluate.
I have now, let's say, a general question about the management of those patients, because we understand that the key part of the treatment is revascularization, is stenting of the SMA of the celiac artery. But there is maybe a group of questions from the audience about medical treatment. When we perform stenting, we give patients anti-platelet therapy, anti-aggregation therapy. We, for instance, provide dual anti-aggregation therapy for a month, and then during the rest of the life of the patient is going to get aspirin, for instance. But is there a room for any other medical treatment, calcium channel blockers or statin, or anything that would help prevent the progression of the disease or prevent the reoccurrence of the disease? Who wants to comment on that?
Usually these patients in our center, we give these patients consultation with a cardiologist. And I think these patients should see the cardiologist if they doesn't see before. Because usually the severe stenosis is a severe stenosis as in every artery, and is a sign of a systemic cardiovascular disease. And usually these patients, if they are not under medication such as statin, they should have statin then, aspirin, statin, and smoking cessation. And I think if a gastroenterologist deal with this kind of patient for the first time, and if mesenteric ischemia is the first cardiovascular event in these patients should all have a thorough cardiac evaluation by a cardiologist and secondary prevention of atherosclerosis disease.
Okay. I see also a comment about, so we don't have time to talk about acute mesenteric ischemia, clearly, but I would like you to react on the aspect of the bowel. If a patient would undergo open surgery of the superior mesenteric artery, what would be the appearance of the small bowel? Should we see ischemic lesions, or is the bowel going to be unremarkable? Because I think it's a key point. There is a difference between acute and chronic mesenteric ischemia on this part. So Luc, maybe you can.
I'm not that much of an expert on acute mesenteric ischemia.
No, in the setting of chronic.
In chronic, when you're performing surgery, it's not the entire bowel is affected. So it's mostly mucosal ischemia, so on the inside. So externally, you won't see a thing.
Yeah, that's very important for the audience to know. It's true for surgery, and it's also true for CT. For CT, we see the vascular anomalies, but the small bowel or the colon are non-remarkable. They appear normal, and this is why it's also quite difficult to diagnose. And also to react to another comment, you can also check for collaterals in chronic mesenteric ischemia and in chronic vascular anomalies. Check, for instance, look carefully to the inferior mesenteric artery that may be really enlarged compared to a normal patient. That's a sign that there is something chronic going on, that the vessels are adapting to the chronic deprivation of the blood. So yes, that might be a diagnostic hint, showing that there is a large other vessel trying to compensate for the chronic ischemia of the bowel. It's also something that you should have in mind. I had maybe one question from the audience. Do you consider Buerger disease as a differential diagnosis of chronic mesenteric ischemia? Is it one of the things you think about or not?
The main or the most important causes of chronic mesenteric ischemia, at least, are the ones discussed. So atherosclerosis is most probable, followed by median artery ligament syndrome, then chronic NOMI. Of course, vasculitis can cause mesenteric artery stenosis, but it's very, very rare, so quite uncommon.
And it's also true for chronic NOMI, which is something that maybe a lot of you didn't really know it existed. Chronic non-occlusive mesenteric ischemia. how do you manage those patients? You have to treat the main cause, you have to treat the systemic reason for chronic ischemia of the bowel, but here there is less room for stenting. And so could those patients benefit from medical therapy, from vasodilatation?
In our center, we have a scheme to start vasodilative therapy, for example, with isosabide mononitrate, so nitrates. But we closely monitor those patients and usually ask the cardiologist, for example, to be in control when subscribing the nitrates, because they are more aware of the cardiac condition of the patient, which can, of course, be influenced by administering nitrates as well.
Okay, I see one last question about imaging. Is there a value in finding a delayed mesenteric venous return? Something that we think about and talk about from time to time. Actually, there is no evidence about that. It's intuitively something we can understand. If there is an ischemia, there will be a delay in the filling of the superior mesenteric vein, for instance. But that's not really something we can really see. So it may be true, but that's not very, very useful in practice. I think we pretty much answered all the questions from the audience. I didn't really address those about acute mesenteric ischemia because I think it's quite a little bit out of the topic, but feel free to send us any message and then we will help you guys. I think we have one last. How can a gastroenterologist really help? It really looks like a vascular surgeon would be more helpful. This is a provocative question, but I think we have time to answer it collectively. From my part, I would say that it's really not only a vascular surgeon problem, because as radiologist, I know that we are really helpful for the diagnosis and for triggering the possibility of this disease when we see a patient that possibly was not aware of that. And we also act as interventional radiologists for the stenting part. But for you guys who are gastroenterologists, how can you answer this question?
I think that the role of gastroenterologists is major in this disease because these patients are recruited by gastroenterologists. These patients see gastroenterologists for their GI symptoms, and so that's the way the first they see the gastroenterologist. In acute mesenteric ischemia, they see the emergencies, they see the intensivist. In the chronic disease, it's the gastroenterologist. And in the main, the most challenging thing in chronic mesenteric ischemia is to make the diagnosis, is to suspect the diagnosis and to rule out alternative diagnoses to reach the diagnosis of chronic mesenteric ischemia. So this very challenging diagnosis part, the gastroenterologists have a major role in this part, which is the major part and the major challenge in this diagnosis.
Thank you very much. I think that Luc will agree to all you just said. Yeah, it's the difference between treatment and diagnosis, and patient needs to be diagnosed first. So I think it's time for me to thank both of you, Luc and Alexandre, for the tremendous presentation and for your time. Thank you also to all the participants who actively interacted with us. It's also important for you to know that the chronic mesenteric ischemia guidelines will be available on GI Guidelines app on Friday. And it's also interesting, I think, to remind you of the upcoming webinar about COVID-19 in gastroenterology. I would like to thank you very much to all of you. And I would like to wish you a very good day or evening or night, depending on when you are. Goodbye.
Thank you.
Thanks. Bye.